Welcome to the PalliEM Podcast. I'm your host, Justin Brooten. Today, we start off PalliEM Podcast version 3.0. I took a bit of a hiatus after the birth of our second child, and I'm glad to get back to recording the podcast and bring back some guests that I think will be excited to hear more from. I'm joined today by my new co-host and Associate Program Director of our fellowship program, Alex Zirulnik. I'm Justin Brooten. I'm the program director for the Hospice and Palliative Medicine Fellowship at Wake Forest University School of Medicine. And I'm also an emergency medicine physician, and I split my time between palliative care and between emergency medicine. Alex, tell us about yourself.
My name is Alex Zirulnik. As Justin mentioned, I'm the Associate Program Director for the Hospice and Palliative Medicine Fellowship here at Wake Forest University. I actually have a primary background in emergency medicine. I did my training up at the Harvard-affiliated emergency medicine residency in Boston, split between MGH and Brigham. And then I came here to Wake Forest University for a fellowship in HPM. And I was just really lucky and glad to stay on for a faculty position here, where I split my time primarily in the ED, 70% of my time, but I do 30% of inpatient consults for the palliative care service here.
And we're excited today to be joined by Caroline Meehan, who we worked on a new paper that's come out looking at the emergency medicine workforce going to palliative care. There's been a big uptick in the number of people in emergency medicine who are doing palliative care training. So we're excited to be able to share that with you and hear more from Caroline. Caroline, tell us more about yourself.
Thanks, Justin. Happy to be here. So I'm Caroline. I'm originally from the Chicago area. And I, like the rest of y'all, did my primary training in emergency medicine. I did that at Brown in Providence, Rhode Island, and then ultimately became really interested in palliative medicine, stayed on at Brown and completed my hospice and palliative medicine fellowship there. I think EM embedded palliative care models have been a really rapidly growing model. And I was fortunate enough to learn of an opportunity up the road at MGH, where they were expanding their ED embedded palliative care team. And so I've been working at MGH since the start of my third year. And I have the inverse of Alex. I do 70-30, but the bulk of my time is palliative care, with the majority of that time being split between our palliative obs unit as well as our ED embedded model. And then I do 30% just standard clinical emergency medicine. And it was my first year as an attending at MGH where I got to meet Alex, who was a Hammer resident at the time. And we've stayed in touch over the past couple of years. And it's been really wonderful to be colleagues from afar and get to collaborate on some projects together, including this, and get to meet folks like Justin. So thank you for having me.
Absolutely. And you played a big role along with Alex in getting this off the ground. It had been something that you envisioned for a while. I know when Alex was starting off as a fellow, he started talking about this and saying, hey, I want to get some data on this. I want to take a look at all the people in emergency medicine going into palliative care. And Alex, tell us a little bit more about what you discovered in this process and kind of what what kind of got you interested in bringing this to bear so that we could share that amongst our colleagues that are interested in this space.
Sure. Yeah. No, I ever since medical school, I kind of knew that I had the spark for hospice and palliative medicine, and I knew that I was going to probably pursue a career in a split position. I think what I was not expecting was when I was telling people over the years of my emergency training that I was going to do palliative care, they kept saying, wait, what? You can do that? And so I was really inspired. And I think my whole purpose and goal in life at this point in my career is I hope at one point, people are going to hear folks coming from emergency medicine going into hospice and palliative medicine and say, oh, that sounds great. And that's totally normal. So I wanted to normalize that. And I wanted to make it known to all the people who are inspired to go into hospice and palliative medicine from emergency medicine that this trend is growing. There's a lot of us out here who are interested in both. And, the field is kind of unlimited in terms of all the opportunities that are out there for us. I came into fellowship, and I think we had kind of heard, I had heard through a lot of interviews through fellowship that, there's a lot more EM folks kind of on the trail going into palliative care. But I don't think that we've actually kind of put a numerator on that yet. And we were not sure how many people were actually doing it. So that was one of the big drivers for us.
And Caroline, kind of with your experience, what was some of the other things that led to the impetus of this paper? Similar experience to Alex, or what would you add?
Yeah, I think a lot of what Alex said resonated with me as well. I didn't even know hospice and palliative medicine was a fellowship you could pursue from emergency medicine until I was about to start my fourth year. And then I had to scramble to get all my application materials ready. So I think, and yet, like, I do think awareness is really growing. And even in the last, I think about the past 4 years of attending AHPM and our little EM significant interest group within that subset of people, just the amount of energy in that room and the numbers growing year to year. And we all talk anecdotally about how this is a growing field. There's so much opportunity and overlap. And yet, like, there's really previous to the study, there's really very little information available publicly online about how many people are dual trained in EM and palliative care. And I think as I was sort of scrambling in this really new combined field to think about career opportunities for myself, so much of this is really through grassroots, just talking to the handful of folks who I knew were in this field, and they connected me with others. And then you realize there is an enormous web. It's just, I think it's still in its infancy enough that the numbers are small, and just wanted to bring awareness to the growing group of us and some of the factors that could be contributing to that.
For either of you, what do you think is the most maybe surprising finding that we have in this study? What surprised you as we dug into the data and got the actual facts on where we stand?
I think for me, I think it was kind of the explosion, especially after COVID. We started, when we were looking at our data, we looked from 2016 to 2023. And in 2016, there were a mere 11 people who were going into hospice and palliative medicine from emergency medicine. And that number has just exploded. In 2023, it was 55 people. So really, every few years, we looked at the number of people going into HPM from EM, and it's increasing by about 25 to 27% every year. So I think that was kind of one of the surprises to me was, and maybe it's not surprising, that after COVID-19 pandemic in 2020, we saw a huge increase in number of folks going into HPM. And we can speculate for all sorts of reasons why that's going on. I'm sure we all have our own personal experiences and thoughts around it, but I think that was a big takeaway for me.
Yeah, I think for me, I was really struck by the match success rates of EM applicants. I think especially because it is still somewhat unknown. There are programs that have never had an EM provider in their fellowship, and I certainly found as an applicant that there were programs that were a lot more friendly to someone with an EM background, and I think could see the overlap there and potential hybrid for these two things. But I think there were plenty of programs that like EM, why here, why now? But I think it speaks to, because, and this is something I do think is changing, especially as it's becoming a sort of a core tenet of emergency medicine training, having some of these primary palliative care skills. But I think it speaks to the fact that a lot of programs don't already have palliative as part of their EM education. And so I think there's a self-selecting group of people that are interested in palliative medicine, that are seeking out opportunities, and potentially are pretty strong applicants that are pursuing this with those backgrounds, because it's not something that's standardly part of a lot of EM residency curriculums presently.
Yeah, and I do think it's improving. One of the things I've been really super excited that Alex has been able to stay on faculty with us is just the amount of education we actually need to do that can still be integrated into the framework of emergency medicine, right? When we talk about pain management, we can incorporate what cancer patients, what their pain management challenges are like, or what you do when you have someone come in that has acute pain that's already on a really, really significant opiate regimen, because that's stuff that they need to be comfortable with.
Yeah.
So I think that there's
a head bleed, having a component of that be a goals of care discussion. It's really it's integrated in all of the care we're doing on a day-to-day basis already.
Correct. And I just think about the topics. I've been fortunate to have his help because there's so many topics we need to cover. The other thing too is you definitely need to have a residency program's buy-in, because they need to be able to see that investment in time that they're giving up for conference, especially in 3-year programs, which eventually it sounds like we're moving to 4-year programs across the board. Just the amount of time that has to be given to each topic to be able to cover an EM curriculum, you can only spend so much time on each thing. So they have to see that it's high yield. And I feel like Alex and I both, I feel like the lectures we've been able to give that fall into this space, I feel like they've been well received both by the residents and the other faculty. So that's encouraging.
Yeah, that's cool.
What the other thing too, I think that makes such a difference, and you alluded to this, is having the residents come in, and some residents come in and they've been at a medical school where they got almost no exposure to palliative care. They didn't know it was something you could go to from EM. And if they're at a residency program where this is at least like brought up as a topic, they can start to unpack that and go, oh, wow, this is pretty interesting. It actually overlaps with a lot of what I do. Both of you happen to be at a place where you got a lot of exposure to all of this. So it was ripe to be an opportunity after completing residency. What do you think is the challenge still in getting the education move forward, or getting awareness for this for people that are training now or moving into EM training?
Go ahead, Caroline.
Yeah, I think one of the, so I was late to be aware of palliative as an option for an EM applicant. And I think in part of my awareness was that we had someone who had trained at Brown, who had an EM background, who was coming back as faculty. So I started some conversations with her. But I think that was such a huge piece of it, was just awareness of this as an opportunity and seeing role models in the field who are working in careers. I think so much of for, at least for me, when I think about what I want to pursue next, is seeing an example of someone who's already doing it and imagining like a similar lifestyle for myself. And so I think with this rapid expansion of EM folks going into hospice and palliative medicine, I think we're going to see more and more folks seeing potential role models or examples of careers that they would want to model their own after. And so I think exposure is the biggest barrier, just people being, because I think so much of it's striking to me just how many residents are interested in hospice and palliative medicine. I feel like so much of the sort of stereotype of emergency medicine as being these sort of cowboys who want just purely procedural lives, but we're doing this work every single day, just given the nature of what emergency medicine is. So I think people recognize that it's an important skill, and there are folks who want to go into it. And I think seeing an example of someone who's doing it is the first step.
Yeah, absolutely. And I think to echo that sentiment too, I mean, there's like 66,000 emergency medicine physicians in the country, and there's only, I think, dual boarded around 315 EM, HPM folks out there. So we're like less than 0.5% right now of the EM workforce. But as we continue to grow, and I think this was a big inspiration for our paper, as we're seeing this explosion of emergency medicine folks going into HPM, I hope that continues to be a big role model. I don't know how to say that. A good way to emphasize all the different role models that are going to be out there for folks who are interested in this field.
And one of the things that I feel like we come back to a lot is you're going to see a patient that falls into our realm almost every shift, depending on where you are. You think about, as many head bleeds as we treat, or as many other things that we treat that are pretty serious, like how many patients a shift are you going to have, flash pulmonary edema? How many patients a shift are you going to have, a bleed with shift, right? But you're going to have somebody with a palliative care need almost every shift, depending on where you are. I can certainly say that. So the other thing that's interesting to me, I was pretty surprised by just now granted, it's a big increase in part because 2016, you started with 11 people that were getting trained in palliative medicine, but an increase of 400% over that time period, 2016 to 2023. I think some of the things we've mentioned all contribute to that increase, but what are some other things that you both think have led to that huge increase in the number of people in EM that are interested in palliative care and seeking training?
I do think I'm going to speculate here, but I do think that the pandemic kind of taught us a lot in terms of providing value congruent care to folks. I think the pandemic played a large role in, I don't want to use the word burnout for emergency physicians, but I'll skirt around it and say a lot of emotional fatigue that people face in the ED. And I think when we had a lot of folks, I was really fortunate when I was at MGH that we had embedded palliative medicine in my training. And it was just so inspirational to see people who were very, very sick during the pandemic. We were all very worried that they were not going to do very well. And then you had this I want to say, team of heroes from palliative medicine that was able to swoop in and have these really difficult conversations under duress while the EM team is doing other things to try and stabilize and seeing other patients. And it was just inspirational to see, how you were having these conversations with folks, oftentimes alone, oftentimes using video recording devices to get other family members involved. And for me, that was a huge inspiration. And I think a lot of folks that I was working around were also inspired and kind of introduced to the field of palliative medicine at the time. I think that's one reason. I don't know. I don't know what your thoughts are, Caroline.
Yeah, Alex, I think everything you said really resonates with me, and so much of this is conjecture, but I personally, I think the pandemic hit about halfway through my residency, and we were a busy critical care center, and so it wasn't as though it was the first time I was seeing patients who were actively dying at end of life. That was a big part of sort of day-to-day emergency medicine. But I think being involved in more of the conversational piece and decisional piece was a first for me, at least during the pandemic. And I think a first for a lot of emergency departments, depending on how they structured resource utilization. So when there simply aren't enough ventilators to go around, there aren't enough ICU beds, suddenly you're thrust into having some of these conversations about who's going to get care, who wants to get critical care, who do we think it will make a meaningful difference in. And so it was really the first time that in the context of the ER, I was having a lot of those decisions beyond the sort of nuts and bolts we're all doing of DNR, DNI, basic code status conversations. I was really thinking about care utilization and what makes sense and goal aligned care for the first time. And I think, one thing my personal hypothesis is that I think a lot of folks who were trainees at that time were inspired by that. But one thing we don't know about from this work is where in training and in careers were people when they ultimately decided to transition. And I think that's one thing I'm really curious to find out is that was it a lot of folks who were mid-career who were potentially working in the community, seeing the same things in the pandemic, or was it more affecting trainees? And so I think that's a question we have yet to answer and are hopeful to explore going forward. But I think the pandemic was a huge driver. And even after the pandemic, I think one of the big things that impacted so many of emergency departments was boarding. And so even just your run-of-the-mill patient coming in with a UTI, some delirium, some of these conversations that were happening on day 2 when the delirium's not clearing, they're not making improvements, there's a consideration of pressors, were happening in the ED, and the ED team is now integrally a part of some of these conversations in a way they weren't necessarily before pre-pandemic when EDs were getting patients directly up to the floors to have some of these inpatient conversations. So I think it's really put itself at the forefront. I think palliative medicine and goals of care are really at the forefront of the thought process for a lot of emergency docs in a way they may not have been previously.
Yeah, I agree, and I think boarding does have a big impact. For one thing, even working both at a tertiary center and in the community, when I think about transfers, when you started having more boarding, you also had bigger delays in patient transfers. And it used to be that the path of least resistance was just get them upstairs or just get them to the other hospital. But when they're waiting, 20, 24, 30 hours to go upstairs, or they're waiting, 12, 18, 24 hours to leave your emergency room, the invested time in actually maybe changing transitioning their care or changing the goal for the patient, if it's clear that they might want to change their goals, or they might not want to just go the path of least resistance, that time invested actually has a payoff. Before, if they were going to get upstairs in 3 hours, and I remember when I was a resident, and admissions were quick, if they were going to go upstairs in 3 or 4 hours, you were just dragging your feet if you did some more stuff downstairs. But now it's a different landscape. And even getting people to hospice, same thing, right? If you can get them to a hospice bed in, 3 or 4 hours, in pre-pandemic times, it's like, why are you slowing things down, right? Let them deal with that later. Totally. But now, wow, you got a bed, in 3 or 4 hours, and it's not one of our beds in the hospital that we're taking up now.
I think we all have skin in the game now, right? Like if we can do something that will impact a disposition, we're feeling that in a way we didn't previously feel it. Mm-hmm. I think that's a great point.
I was going to say, what do you guys think about, in terms of like lifestyle too? So there's like a lifestyle difference between working in emergency medicine and working in palliative medicine. And it's so funny. My wife was just asking me, she's like, do you feel more tired when you're on your 3 weeks of ED or palliative? And actually, I think it's my palliative week. I'm more tired. It's like the early morning, 8 to 5, and it's so emotionally difficult to go through the day. I just I want to hear y'all's thoughts on what you think about like lifestyle choices too, because I do think that probably plays a factor in some people's decisions to pursue HPM too.
Yeah, Alex, that is such a good point, and I think about that on a day-to-day basis. I feel like I'm I feel really spoiled to be able to split my time between palliative and emergency medicine. And I think if I was doing either one exclusively, I would have a very short-lived career. And I think which one I find to be more emotionally trying and more rewarding, really, it swaps around on a day-to-day basis. So I feel really lucky to be able to swap around. One of the things I always tell residents I'm working with is that I do feel like, there's a high amount of burnout in both fields for good reason. And I feel like some of the things we do in palliative medicine are antidotes to the burnout in emergency medicine and vice versa. So I just finished a long stretch actually now of palliative medicine, and I feel emotionally fried. I don't have an empathetic bone left in my body. I don't want to talk to a friend about some issue they're dealing with in this horrifically selfish way. And so I'm looking forward to going back to the ED and having this like really rapid fire, just transient sort of interaction that's more procedural and interventionally based. And then after a few days of that, I'm sure I'll be feeling like I need a longer connection and want to have more in-depth conversations with my patients. And so I love being able to swap between the two. But I do think the palliative care piece initially, I was like, these are such like when I started my fellowship, I remember I had like 3 hospice patients, and I was like, I could be done with this day in 20 minutes.
Yeah. That's so true. And it's so weird too. I just worked a shift in kind of our fast track area last night too. And it's like, I just saw like 20 people without life limiting illness, with like very minor complaints. And it is just kind of a reset, I think, going back and forth between the two. And it's, but I think it marries well together. And I think, a lot of people don't think about it like this, especially if they're not emergency folks, but like we are trained from day one to know nothing about a person, build immediate rapport, in a way, figure out their goals in terms of like workups and admission, things like that, and meet people in crisis. And I think that's exactly what we do in palliative care consults too, is like, we know nothing about these people. We're being asked to enter their care at the most, critical times often. And, I personally think ER folks are very good at building rapport very quickly. And so I think that again, the two fields marry so well together.
That's such a good point, Alex. And sorry, I don't mean to interrupt you, Justin. I think one of the other things too that people don't always necessarily associate with the ED is that like we're really no strangers to death and the end of life, and I think it's something that you're really inundated with in emergency medicine. And so being able to be in that space and be able to honor people's wishes as a sort of transition of care feels really nice, as opposed to being the person at the head of the bed running a code. And that I found to be a really healing experience, to be quite honest, I think, coming from emergency medicine.
I really like one of the things you said there, Caroline, about it being the antidote for some of the things we encounter in emergency medicine. And I find like I still get excited after abduction when I get to see an X-ray, and I'm like, yeah, like I nailed it, and I feel really good after a really, if I feel like I steered a family that was like, on the ledge or like angry or, stuck and mired, and I was able to help unglue them out of that space and get them to a decision that wasn't easy, but it was the right decision. Like that feels really good. So it's nice how they complement each other. And I bet the two of you probably experienced this, but one of the things when I was in residency, it was evident that this was kind of the space I liked working in. So I kind of developed that reputation. And to this day, like my colleagues will come up to me and they'll go like, yeah, I had a hospice patient last shift. I got a person to the hospice, and they'll be like, you'd be really proud of me. And they'll tell me about it, but their faces light up. Like they get excited. And the irony is, as much as, and I like intubating people. I like putting lines in. I have fun with it. I love defibrillating people, but cardioversion. I really love cardioversion. But like, it's funny, we don't get a lot of thank yous for that stuff, right? And you think about the sickest people we take care of, they just are whisked off, and we're a phantom. They never knew who we were. And I don't mind being anonymous, because they don't have to remember who I was when they make that decision to, for their mom to go to hospice. But that's where I get most of my thank yous. And I think our colleagues see that too. They take these families through that difficult journey. They give them the tough information. They help them process that decision and make a conclusion about it that makes the most sense for the patient. And afterwards, they're like, wow, that felt really good.
Yeah. Justin, that is such a good point. I remember being like a week into my fellowship and turning to my program director, and it's like, I don't think someone said thank you to me in the last 3 years. And like here it's every encounter. And I don't like, gratitude is not why I went into emergency medicine, and it's not something I need at all to find this work fulfilling. But it is nice. It is really nice. And it's nice and I think it just speaks to the types of interactions we're having are so fundamentally different. I think a thank you is not necessarily appropriate in the context of an emergency room visit.
Yeah. I wonder what you guys too. I think about this too. Especially when I'm transitioning like out of the ED onto my week of palliative consults, is like, it's kind of fun to be able to leave the ED and like be in the hospital. And I do feel like it's kind of nice to have a presence, and like you put names to faces when you go upstairs and you're seeing consults, like, oh, you admitted my patient 2 weeks ago. But now I can actually have a conversation with you in a different sphere, and kind of get that relationship, especially like with our ICU teams and ICU docs. I just think it's another, you wouldn't think of it as a reward in going in this field, but I do love that aspect of me splitting my role between the two. Is I kind of get to call
the consultant instead of the consulter. You get to, I think the interactions tend to be a little more positive when you're wearing your consultant hat and interacting with the primary team.
You're not making more work for everybody, like being in the ED.
Well, and the thing that's interesting is in the emergency room, while we are experts in what we do, all the people we talk to are more expert in their thing that we're asking them about. So they there's a different power dynamic. And I think about like when you're the Swiss Army, I think of an ER doc's a Swiss Army knife, right? When we're downstairs, we're a Swiss Army knife. We have a tool for everything, but we're still reaching out to somebody who's a specialist in that piece of whatever it is that they're admitting that patient for. And when you go upstairs, you get to be we're already an expert at something. But I think upstairs when we're consulting, we kind of get recognized for the expertise we have in that space, and even our really good critical care colleagues or whatever, they're like, man, they're really good at talking about this stuff. Or wow, you really helped that family. Thanks for helping with that family. I think that's also nice because it's a different kind of interaction, kind of like you said. It's a different hat we're wearing, but I think it's very affirming, which I'm with you. I get a lot of I get my cup filled just knowing that I did something that I felt was meaningful in the day, but it's nice to get acknowledged. I think none of us, mind that. We don't necessarily have to live on it, but I think that's a good point.
And I think we also, Justin, I think we've talked about this a little bit. Like we also speak the language of every other specialist in the hospital, right? Like we are so used to calling folks and giving a story to, it's going to be very different probably talking to like an internal medicine hospitalist than it would be like a neurosurgeon who has maybe more limited time. So I think that's another great skill set that we bring to HPM is when the teams consult us, like, we know how to speak their language. And we've kind of taught that since day one of emergency. So I think that's also really cool.
I think it's helpful just thinking about the downstairs interactions. Like I think about our surgical colleagues, like when I go to the surgical ICU or I go to the trauma ICU, it's like I was elbow to elbow with these people a few days ago in the trauma bay. Right. So I think that's also something that's nice is we have, because of our niche kind of between the procedural and the medical, they kind of, I don't know. I think they tend to relate. I feel like I relate with the surgeons pretty well because we share some of that space together. And I feel like they appreciate that. And it seems to work. It seems to work well, especially with the diverse patients.
I wanted to ask, have you guys ever taken care of a patient in the ED and then seen them as a consult? Has that ever come up for you?
I have. Yep.
As of
yeah.
What was that experience like for you, Caroline?
It was wonderful, to be totally honest. And I think it was actually someone I anticipated. I was working an ED shift. It was actually just about a week and a half ago. And it was a patient who came in who was end-stage malignancy, uncontrolled pain. And I knew I was going to be the doc on for the week, the next day, wearing my palliative care hat. And so I put the consult in knowing that it would be me. And so it was really wonderful to be able to sort of frame shift and start. I mean, it was like a microdose of what I was able to do in terms of palliative care in the ED, but it was a really cool opportunity to be both the person who initially saw someone from square one and then to continue their care and evolve some of those conversations. And it also is I guess that's like what it is to be a primary team in so many ways, but to be able to understand some of those influences of what did this person look like in distress in their worst moment and have that as context for some of the later days of their admission, I think was really helpful.
I had the reverse direction experience,
Oh
and it was
no.
pretty memorable. So I had somebody where I saw them, no, not reverse in a bad way, like
Yeah.
reverse, like I saw them as a consultant, and then I saw them as an ER doc.
Yeah.
And it was somebody that,
No one wants to return to the
yeah,
ED.
yeah, it was. They had come in and. I actually saw him and I did kind of advanced care planning. It was somebody with sort of advanced pulmonary disease. And I got to talk with him and his wife. And I think we made a plan for like no intubation, kind of based on whatever else had happened or a series of things. And I think a couple weeks later, I was getting sign out and it was like, wait a second. I've seen them before. And like he was not doing good respiratory wise. I can't remember the whole scenario, but I remember it was so unique because I was able to say to his wife, I said, you remember the stuff we were talking about? I'm like, this is the stuff we were talking about. And it was just, honestly, it felt very humbling to be able to kind of bookend that process. Because I'm like, what are the odds? They're not. I mean, it's kind of like divine intervention, like the fact that I was in both of those places. The other thing I've had happen that was similar was people I've seen serial times in the ED, and I've had a chance to see them on more than one visit, and things have progressed or things have happened, and because you've got a rapport with them, it does facilitate a little more in-depth conversation and transitions. But those aren't frequent, but when they happen, they're like, whoa, that was a lot. That was a lot to take in,
I've,
I had some.
oh,
Go ahead.
No.
Oh, I had some similar experiences. We do the ED embedded palliative care consult model. And so it's not uncommon that we get a lot of repeat consultations on the same patients. And there's nothing more powerful, I think, than seeing the physical decline in someone. It's like, remember what we talked about being worried about happening? I think we're there today in comparison to before. It's just a really wonderful. And I guess that's what most outpatient providers get to experience on a regular basis is seeing people at various cross points in time. But we don't often get to see that even as consultants. You're seeing people for like a snapshot of a few days or this discrete ED visit. And so getting to see that progression and those changes is really, really a unique lens. And I think can really impact the care decisions they make and how the conversation goes.
And I think it's really cool too that, all three of us work in academic centers. And so we work with trainees every day. And I've started to do this thing. I'm a new attending, but I've started to come on shift and, introduce myself. And everyone knows I do palliative medicine too. And I'll say to them, I was like, hey, let's try to find like somebody who might benefit from palliative care today on shift, especially in our higher acuity pods. And they're always like, maybe we'll find somebody. Want to know. And by the end of the shift, they're like, I think we need to put in like 5 consults. There's like all these people that probably need palliative care, whether it's uncontrolled symptoms or the family's like in distress and, goals aren't clear. Like it's just amazing. I do think it's so cool to be this presence in the ED. And I think it kind of, as you were kind of alluding to earlier, Justin, like people come up to you excited. Like I think we're kind of like a lighthouse in a way that shines a light on people who really need us when we're down there. And we kind of like remind everyone, oh, wait a minute, like we probably should involve these specialist services.
And I think it also speaks to like that. I have had similar experiences with my colleagues, which is just like the best feeling in the world that someone's excited about having done palliative care in the ED. But I do think we, as a specialty and just as healthcare in America, we do really horrific things to people at the end of their lives. And getting the moment to sort of take a step back and a beat and say like, hey, does this make sense? Is this what you want? Is this really the right path forward? Just, I think can be a really powerful moment in the ED.
Right. And the activation energy to perform very good palliative like medicine in the ED is hard for folks who don't do this every day. Like how much easier is it? I was just talking to a resident about this on shift. Like you have a patient who unfortunately has a pain crisis overnight from hospice. Well, the easiest thing in the world is just like hit the easy button, admit, get labs, get imaging if you're worried about their abdominal pain, and you're done. But to take a step back and like maybe we need to talk to the family overnight, and we need to call the hospice agency, we need to do all those things. I mean, it's a lot more work, but so much more rewarding when you realize that you're providing, again, goal concordant care for a patient who probably does not want to spend what limited time they have left lingering in a hallway or being boarded in the ED waiting to be admitted. So yeah, I think that's another really cool aspect of our job is that we can be there to shield people from that if it comes up.
I like what you said, activation energy, because it is. There's almost like this little threshold that has to be crossed. And I think one of the things that's fun is when people learn just a little bit of language that basically like makes that pivot happen a lot easier than they realize. So it's kind of fun. I joke that they're like Jedi mind tricks. They're really not. But there's just a few things you just ask it a little differently, and it's like, oh my gosh, you got like such a different answer than I was expecting from that family. And it's not manipulating them. It's asking a question in a way that they actually are understanding what you're getting at. One thing I'm curious about as we see this, you alluded to it earlier, Caroline, there's still some digging that we've got to do. There's still some unanswered questions about what this group looks like. Like you mentioned, we know that a lot more people from emergency medicine are going into palliative care. I'm happy to say, I can say from our applicant pool, when we have emergency medicine people, most of them are pretty new in training, and I haven't seen a lot of people that are like coming like late career and they're just like, I've had it, I just need to do something different, which unfortunately sometimes people can see palliative care as an off-ramp for that. But most of the people I've seen, it's been very intentional. It's been very much like a guided decision or kind of an epiphany that they had during residency. What are some of the next steps that you think we have in this space to kind of get a better idea for what the workforce looks like and where are they at their careers and what is that next step that needs to be explored?
Funny you should ask that, Justin.
It's almost like that was planted.
So I think the next step really is exploring what does this group look like? Who are they? Where are they coming from? Where in their careers are they? And what is driving the factors for one, exploring a fellowship in hospice and palliative medicine. But then the other thing we don't understand presently about this workforce is how many folks are splitting time between EM and palliative care. I would imagine my hypothesis is that we're probably a minority of people who are still doing both clinically. I think the majority wind up in one camp or the other. And as I experienced, and I'd be curious to hear your guys' experiences as well, it was hard to find. I wanted to do both. I was in the camp of people. I didn't go into hospice and palliative medicine because I was running away from emergency medicine. It was a genuine passion and a desire to combine the two. But it was tough to find institutions that could buy in. And I feel really fortunate to have found one that allows me to do both. And there are very real drivers that are kind of continuing to play and making that balance somewhat difficult to manage as opposed to just having a single house to be within. But those are some of the questions we were really curious about. And so Alex and I are hoping to launch in accordance with the rest of this group. And I think, Justin, you're involved as well, and surveying some people who have primary education in emergency medicine who have gone on to pursue careers in hospice and palliative medicine and some of the driving factors that went into those decisions, and then what their practice model is and other factors that contributed to that. But because we can hypothesize until the cows come home about why people went into hospice and palliative medicine, but we really want to hear from the horse's mouth what those factors were.
Yeah, and I mean, all three of us were sitting in Denver last year at HPM, and I think it just started like popcorn in this room of like 100 people of like, wait, what do you do? And how do you split your time? And like, we all want to know what we're all doing, but no one's ever like looked at this before. So I think having that data out there, almost as like a reference for folks who like, let's say, you are mid-career or you are an intern and you're interested in HPM from EM. Like I hope through our work together as a group that, they'll have like a reference to go by and say, okay, well, there's a lot of folks going into fellowship. That's totally normal now. And then what do I do after I've done fellowship? Like, what are the options? And what are some of the driving factors that I should think about when I'm thinking about this career? So, I'm really excited about it. I think most of us who do work in this field from emergency medicine are excited to tell our story because our stories are pretty unique. Again, we're less than 1% of the EM workforce. And so, I think it'll be pretty great to get that info out there.
And Alex, I think to that point, even though this is such a rapidly growing subset of people pursuing HPM fellowship, it's still, we're often, I think, sometimes the first EM candidate a program has had or one of the first few. And so I think, a lot of programs aren't as familiar with advising career paths for folks coming from EM. And so I hope that this information will be helpful to people.
And And actually, to piggyback on what you said, I think one of the most useful things to help with that, because this does, I think, require some mentorship. So we've got different national organizations that each have like subsections of palliative care interest groups, where we're a fairly small group of people. So that can be a good source of information and guidance. Having worked with several fellows that have looked for jobs, like combined jobs, I think it's helpful to be able to advise other people. I will make a quick plug just because, and I'll be universal on it to include the other groups, but both Alex and I co-lead the ASAP palliative medicine section. So we're happy to provide some guidance and mentorship for those members that want to join us on that. There's also some excellent groups at SAEM, AAEM, and AAHPM, as Alex mentioned, that you have a nucleus of people who have worked in both spaces, have explored different opportunities and jobs in both spaces, and can help be a source of guidance for the people who are looking at, do I want to take a plunge and do this? If I do, what is my job opportunity landscape going to look like? How do I navigate a dual position? I think there's people out there who've done it that can be a source of guidance. Well, I think I really appreciate the discussion, and thank you both for being on today. And I'm really excited about what can come of this next stage of this exploration. And I think it was extremely enlightening to be able to see a little bit of the landscape of who's out there going into palliative care from EM, how much it's increased, and I think it's going to continue to increase because, as you both mentioned, we have kind of an innate skill set in EM to build rapport, to jump in on an emergency, to be able to help people in crisis. And I think that translates really well. And it's continuing to be recognized. And even for those residents who aren't necessarily interested in a fellowship, they see the value in that primary palliative education that they can still use in practice regardless of where they're going to be. So thank you both for being on. And I look forward to the next time we can meet, where we can talk about the next stage of the study. And thanks, Alex, for joining me now as my now co-host on the podcast. And thank you, Caroline, for joining us. I've enjoyed it.
Thank you for having me. You guys are such a dynamic duo. I loved it.
No, I love this group. I love it. So it was really good to see you, Caroline. Thank you so much for being here. And, again, I have to thank you for being a mentor for me back at MGH and helping me finding my way here in HPM as well, too.
Well, thank you for being a continued mentor to me, Alex, and for your enthusiasm behind this work. This has been just such a fun project to work on together, and I'm really excited to see what happens next.
Awesome.
That's what we'll end with.
Okay. I'm sorry. So long.
No, the awesome. I think the awesome is that we're going to end with him saying awesome.
No, I kept saying, I don't even know what word I said, but it's not a word I ever say.
I bumped the mic at one point. I bumped the mic at one point.
I get so mixed up.
I think for a single take, that was really good.
Good.
Yeah, you can edit and splice some parts, but
please cut out anything of mine. I
think it was really good.
We need more role models. I just mean that if people aren't exposed to people in emergency or practice,
I'm going to stop it because it'll. Thank you for joining us on the PalliEM Podcast. Our outro music today is brought to you by my DJ alter ego, Aleus, ALAEUS. You can find my content on Spotify and iTunes and other streaming services. This is a snippet from the track Synesthesia. Thank you for joining us for the PalliEM Podcast, a production of PalliEM.org.